Welcome everyone, and welcome to the ISMP webinar. What have we learned through medication error reporting? My name is Philip Hodsman. I'm the Business Development Manager at ECRI UK, and I'll serve as your webinar moderator. Medication safety is one of the major components in patient safety. Medication error reporting systems are established to identify the contributing factors and causes of errors. This system requires collective effort from regulatory accreditation parties and change the way we manage medication errors. Our speakers will share how reports were used to make recommendations, working with government organisations and suppliers to make industry practice changes and make advances in technology. We're delighted to have with us today two experts from the field, Michael Cohen and Christina Mahalek. Michael Cohen is founder and president at ISMP. Dr. Cohen's work in medication safety has spanned decades and is known worldwide for his passion and contributions to medication safety science. Mike has served terms on the US FDA Drug Safety and Risk Management Advisory Committee and the Non-Prescription Drugs Advisory Committee, and is a current member of the USP Expert Committee on Labeling and Nomenclature, as well as a consultant to the FDA. He is also the chairperson of the International Medication Safety Network, or IMSN. Christina Mahalek is a medication safety specialist at ISMP and administrative coordinator for the Medication Safety Officers Society. She also serves as a patient safety analyst to ECRI and ISMP's patient safety organisation. Prior to joining ISMP, she spent more than 20 years in acute care practice, where she held clinical, management and leadership positions. At ISMP, she works collaboratively with health system leaders and clinical staff to define and improve medication safety initiatives, and often leads national, international, state and regional educational programs. Christina manages the update and analysis of ISMP's targeted medication safety best practices and is the lead for medication-related technology issues. She also serves as the chair of the Leapfrog Barcode Medication Administration Expert Panel and co-chaired ECRI's Partnership for Patient Safety Health IT Clinical Decision Support for Drug Allergy Interactions Work Group. Over the next hour, our speaker team will discuss the role of error data and confidential reports and how both are critical to improve medication safety. We encourage all attendees to participate in the conversation with discussions in the chat tab at the bottom there, and to ask any questions in the Q&A tab. I will now turn over to Mike.
Well, thank you very much, Philip. Hello, everybody. Welcome to today's program. I don't know, most of you aware of ISMP. You've heard of us perhaps, or the International Medication Safety Network. I've actually interacted with a lot of people from the UK, from England, and also Europe, through the International Medication Safety Network. And as a matter of fact, we have several regulators that are involved with that, including EMA and your MHRA. And I've been involved from time to time with some of the projects in Europe, in England in particular. A few years back, I got to work with my colleague David Cousins, who will be with us in a little bit for the question and answer session, on a project that was about diluting vincristine in a mini bag. And I've also interacted with EMA when they were in London, and that was on insulin safety projects. But we thought it was a good time. We actually affiliated with ECRI, and we're both nonprofit organizations. We thought it was a good time to get back in touch with our colleagues in England and the rest of the UK and in Europe, and kind of update them on how things have been going here with our medication error reporting program. That's really our total focus at ISMP. And we affiliated with ECRI back in January. So, you know, a lot of good things have been happening since then. For example, here in the United States, we have a federally recognized patient safety organization, which we merged our efforts and ECRI's efforts. And we have a large number of hospitals that are actually members of the PSO. And we're doing some other things as well, including creating a membership category to make certain things available to people that join the membership. We're continuing on with our regular activities, of course, and our focus on medication error reporting and turning that information around as a benefit to educate people. And I'm talking about the entire healthcare community on labeling and packaging issues, device-related issues that touch on medication errors and nomenclature issues, but also practice-related issues as well. And we've been a long-time follower of things that have been going on in Europe, as I was saying. In particular, you know, we're in touch now and then with not only David through the International Medication Safety Network, but also with the medication safety officers who are with the National Health Service. And we learned a lot over time and have shared a lot of information, a lot of important information. So I really do think we've made great progress. I don't mean ISMP, I mean really the world. It's so much different now than it was 20 years ago, and I think our patients are a lot safer for it. And really that is what I thought we would spend some time doing. I'd first like to just quickly go over what we do here in the United States through ISMP and the medication error reporting program. And then later on when we have questions, and David will join us, and you may remember David as the former head of safe medication practices for the National Patient Safety Agency and the National Health Service England. And we used to follow David's work. We picked up on a lot of things that the National Patient Safety Agency did. In many ways here in the United States, we serve a similar role, although we are not funded by government. We are sanctioned as a patient safety organization, but our funding as a nonprofit is on our own. And a lot of it comes from donations and grants, but also educational programs that we do and work that we do with hospitals in the United States, and to some extent outside the United States as well. So we did think it would be useful to update you. May I have the next slide, please? And let me just say that Jordan Rufo is with us. Jordan is the technical advisor to this program, and she's really pulled it all together for us, and she's behind the scenes now, and she'll be advancing our slides, and then Chris will come on after me, right after me. So just so you know, we're a nonprofit. We're actually a public charity, so we're tax exempt. And it really started many years ago. We did a column very similar to a column that David Cousins, Dr. Cousins, ran in a pharmacy journal in England, along with another gentleman, another pharmacist named David Upton. And we expanded in 1977 to a nursing journal called Nursing 77. That column is still published today, and it's a monthly column. And it really gave us an opportunity to interact more with our colleagues in nursing, not just our pharmacy colleagues. And also, we interact a lot with the medical organizations here in the States, like the Anesthesia Patient Safety Foundation, which is mainly anesthesiologists and anesthetists that are interested in medication safety, particularly in the perioperative areas. Our mission is to advance patient safety worldwide by empowering the healthcare community, and we touch on consumers as well to prevent medication errors. And I'll show you in a little bit, we have websites for consumers. We have a consumer error reporting program. We learn from them. And we also have websites for the medication safety officers. We have at ISMP the Medication Safety Officer Society, and we have nearly 3,000 members. And it's international. So we welcome anybody to join that. There's no fee or anything like that. We do have the good fortune of having a formal agreement with our Food and Drug Administration here in the States. And you may not know this, but that's a very strong relationship. We speak to them or interact with them almost on a daily basis. We meet with them formally once a month, and we meet face-to-face twice a year. And they have an entire division called the Division of Medication Error Prevention and Analysis that does nothing but medication safety work, medication error prevention. And they touch on the development of drug naming, particularly the trademarks, and also anything to do with labeling and packaging. They work with the various divisions that approve the drugs within the Food and Drug Administration. So they have a very important role, and we get to interact with them quite a bit. We also interact with the United States Pharmacopoeia. You heard that I am a member of the Labeling and Nomenclature Committee, and there's an entire chapter in the USP that's a standard that all of our pharmaceutical industry must follow in order to put a product onto the market. And so much of that has come out of the willingness of people to come forward altruistically and tell us about events that have happened to them or concerns that they have, that there may in fact someday be a serious error because of product labeling. We try to turn that around through development of standards, helping USP, helping FDA, and that is a big part of the progress that we've made here, I have to say. Our efforts really at ISMP are totally on preventing medication errors. And it turns out that with the millions of reports that we have, with the ECRI and the ISMP Patient Safety Organization, millions of reports, about 30% of them are patient safety issues related to medications in the United States. So it's really big numbers. Multidisciplinary staff and board of trustees, and our work impacts the FDA, USP, and accreditors in practice that oversee the provider organizations and the work the providers do, such as the Joint Commission. And in the United States, our Center for Medicare and Medicaid Services, which is our government agency that oversees healthcare and insurance for those with renal impairment, disabilities, and patients 65 or older. And hopefully someday, very soon, we'll be expanding availability of Medicare outside just what I just told you. That would be very nice to see. We're one of the only countries in the world that doesn't make healthcare available for pretty much everyone, as most of the rest of the world has. So we're hoping to see changes like that soon. Next slide. So very easy to report. ISMP.org is our website. You just go there, and right on the top, you can see the error reporting. You click on that, and it takes you right to our error reporting program. Next slide. We do ask that you fill out a very, very easy form. We are not out to ask you to fill out multiple fields. Just tell us your story. We'll take care of the rest for you. We want to know what your concern is. We want to know what you think should be done about it. And if you've taken any steps, we'd love to know about that too. Those are the 3 questions we ask you. We also have a vaccination error reporting program in addition to the consumer and the acute care and community reporting program. So we really hear from the whole spectrum of healthcare with these programs. And don't let me confuse you. I talked about the millions of events that we have through the Patient Safety Organization and all the learning that goes on with that. But the reports I'm talking about now are provider reports. We hear directly from the pharmacists, doctors, nurses, PAs, physician assistants, anesthesia personnel, et cetera, et cetera. They tell us their story. We interact with them. And then we do some investigation. I'll show you that in a minute. And the learning goes out in our newsletters and recommendations to USP and FDA and the drug industry. We hear from consumers on the left, from practitioners, from the medication error and vaccine error reporting program. Because of our legal agreement with FDA, we have a memorandum of understanding that we both signed. We are able to obtain reports from FDA that were sent to their MedWatch program, the FDA Adverse Event Reporting System. And we can do that without going through the normal Freedom of Information request that most people would have to go through. So it really speeds things up. We can get information in a matter of sometimes hours or days, when otherwise it would take literally weeks. And we also benefit from other sources. In the middle, in the circle, we've been very fortunate to see interest in other countries over the years And we've developed the IMSN, the International Medication Safety Network. But earlier, we also worked with Canada, Spain, and Brazil to develop sister organizations that are related to ISMP, but not formally. We license our name, we interact with them on a regular basis. They handle things pretty much the same in their countries. The output is to practitioners, organizations, consumers, regulatory, and industry. Next slide, Jordan. Our newsletter is, goes to every hospital. The one you see there is acute care, goes to every hospital in the country, and it serves as an early warning system. When something very serious comes out, we have what we call the National Alert Network. We work with the American Society for Health System Pharmacists and USP, and we get the information out literally within days if something very serious happens. For example, in September, we launched a National Alert Network because of several errors with tranexamic acid, the injectable, that was accidentally given intraspinally instead of bupivacaine for regional anesthesia. It might also, one of them was epidural for regional anesthesia and obstetrics. It was secondary to lookalike drug vials, and also the way the drugs were stored, and other factors as well. We made a number of recommendations to hospitals around the country who are handling that. We found in one article alone over 20 fatalities from just that happening. Our reporting programs about learning and change, and then of course the standards and guidelines. Next slide, please. So basically just look at the circles there on the bottom. We get the narrative information, and the reports are received, they're investigated. We use them to inform through our newsletter, and prevent is what we hope people will do with the information. I think, unfortunately, like I'm sure you experience, and with your reporting program, I just am reminded now by David, it's over 250,000 reports that you receive each year. And, I'm afraid that the one big problem that we have, not everybody reacts to these. And I'm afraid that we still have a situation where people wait for something to happen before they take action, and then they look in the literature and see what ISMP and others have published for prevention recommendations. We've tried for years to reverse that. I think we've made good progress, but unfortunately that is still the case. So I think you have a leg up on us in the UK with your NHS, for example, and that's not necessarily shared in Europe, obviously. You have the authority to perhaps even require that certain steps be taken. It's expected that that be done. We have no such agency in the United States that oversees these medication errors that we have, and many of them are very serious in nature. So there's no one that focuses just on medication error and makes sure that these are reacted to. Next slide. These are our other newsletters. We have them for long-term care, nursing, acute care, consumers, safe medicine, and all the way over on the right for community and ambulatory care. Next slide. So we have a pretty big circulation. We also do the journal columns. Oh, this is that national alert. I forgot that I had the slide here. And the problem that we found was a lot of them have the blue caps that you see there. And if they are standing up and below eye level, people have picked up the wrong vial and put it back in the wrong place. And then unfortunately don't read the label, and unfortunately draw the wrong medication up and then give that instead of bupivacaine for anesthesia. Next slide. That's a worldwide problem. These are our websites. On the left are acute care. In the middle is our Medication Safety Officers Society. We do bi-monthly webinars for our members, just like you have invited us to your medication safety officer gatherings monthly. Nicola Wake runs those or oversees them. We invite you to join our Medication Safety Officer Society and also participate in our webinars. It would be great to be interacting with others in Europe, the UK, and wherever else we would find interest. We do have a number of members from around the United States, and you know, it's been really great to see that type of interaction and learning from one another, which is what we try to do with the International Medication Safety Network, which you can type in Google or a search field and, you know, take a look at the information that we have on our medsafe.net International Medication Safety Network. Just type in IMSN and you will find us. And then all the way over on the right is our consumer website. And we have special sections for insulin safety. We have special sections for over-the-counter drug safety. I think a lot of the things that we have recommended are you have been doing. You use a lot of patient packs, for example, specific numbers of doses for a monthly supply. In the United States, our opioids are still dispensed largely in bulk containers. You know, 30 tablets, 60 tablets, 120 tablets loose. And I will tell you that the counts are off sometimes, and we don't know what happened. That would be overcome with things like you're doing. So we've recommended that here in the United States, and we have some uptake with that. Not a lot, but it's beginning to happen. And there are other things that we have learned from you, and hopefully we can learn from each other. Next slide. So that is our MSOS. It's been around for years. We have the webinars I told you, lots of opportunity to collaborate. And at ASHP, that's the Hospital Pharmacy Group, we do a lot of in-person networking. Next slide, please. This is just one that goes back many years that we have been successful with. We do not allow potassium chloride concentrate injection on nursing units anywhere in the inpatient area. It's just not allowed. We have pre-mixed containers, pharmacy prepared containers, or even mini bags of more concentrated solutions, but they're diluted down. And it's really eliminated the types of errors that we see around the world, including, unfortunately, in the UK, where somebody draws up KCl concentrate instead of sodium chloride or another drug due to lookalike containers or poorly labeled ampules, and then injects that directly and stops someone's heart. So we have recognized that problem, and our Joint Commission joined in with us and said no more storage, and we inspect hospitals. They inspect hospitals, that is. We have no authority to do that. And they see to it that that is not outside the pharmacy. So that's been a real help. We focus a lot on these major issues. Next slide. Here's another issue that we've worked on, and you've picked up on this, and we picked up on it many years ago, and that is with the drug vincristine, the cancer drug. And unfortunately, in hospitals around the world, and we just had little children die in South America last year, which we had in our newsletter. Unfortunately, the vincristine is prepared in a syringe. And I know you did take action, at least for adults. And I think, you know, there was a lot of oversight in the UK by Sir Liam Donaldson at his request for people to look into this. And I did get to come to London and work on an effort to put the vincristine drug in a mini bag so that it would never be confused with anything in a syringe like methotrexate, or that is given intraspinally, or a steroid, or cytarabine, or whatever else it might be. So I will tell you that that has really been terrific here in the United States, and thank goodness we have not seen an event. We don't want to see an event in the US for many years, but we do still see them around the world. And I know you've been successful with that as well. We did not limit it only to adults. We do use this for pediatrics as well. And also, we did a baseline survey of US hospitals, and at the time, about 40% were diluting in a mini bag. And then with a lot of publicity and a lot of enforcement, even our Food and Drug Administration took syringes out of the labeling of the official labeling for vincristine injection. It's not there anymore, only mini bag is. We're up to about 85%, the last survey that we did. Next slide. And that's a picture of the container versus the syringe. Next slide. We have a list of targeted medication safety best practices that we've been working on here. Also, we do baseline surveys to see where people are before we implement these. These are freely available on our website. We'd love to share them. You can download them. And next slide. We have a list of them on this slide. Oral methotrexate is one that we've both been working on. I know EMA came out with something last year. You know, we're still weighing people in pounds. Just, I think you are too, unfortunately. And our volume, we're still using a lot of household measures like teaspoons. We have really been pushing for a milliliter volume, and unfortunately, that's been a source of error. We don't have time to go through all these, but you can see what they are on the slides, and you'll be getting a copy of the slides. So any questions? And we have detailed information on that book, in that booklet that I showed you on the previous slide that you can download. And hospitals have done this voluntarily. It is really amazing to see something go from 20% or 30% all the way up to 70, 80, and 90% to reduce harm. Next slide. So this has been a lot of progress. This is our MOU with FDA. Next slide. We've done a lot of work on preventing drug name mix-ups. I know the jury's still out on tall man letters. I think there are things that could be done to enhance the visibility of the unique letter characters, like using color backgrounds, larger fonts, italics, background colors, et cetera, that haven't been studied yet. But I do believe we have a serious problem. We are totally electronic now, and continuously we have people that will type in the first 2, 3, or 4 letter characters to choose a drug, and other drugs that begin with those letter characters appear on the screen. Some of them have the same strength, and it's very often that we get reports of name mix-ups where just that has happened. Metformin 500, metronidazole 500 is a common example. So we're working hard on that, and we're also hoping to do a study on the other ways that the tall man letters can be depicted. Next slide. Name mix-ups, believe it or not, one of these was a wart remover, and the other one an eye drop. Yeah, we got the wart remover company to change the name. Boy, imagine putting that in the eye. Next slide. This is something I don't know that you've done, but we have reduced this R down to 0. And this is a problem where on the left, the old way of doing this, and it's been around now, we made this change years ago. We used to have the per milliliter designation as the primary designation, and nurses would look at the vial on the left and say, oh, this is a 10,000 unit vial. In fact, it's exactly the same amount as the one on the right. We now use the total volume as the primary display and the amount per milliliter underneath, and that error has gone down to 0 now. And it was a very frequent error, and that was a standard that USP came out with, and FDA requires that all manufacturers do it this way. We've had occasional incidents where the manufacturer didn't do that, and we get it reported from the field. Next slide. So yeah, I just wanted to give you a couple examples. There are guidance statements that are right out of the reporting program for largely the USP standards are right out of the reporting program. Next slide. And I do think we've been making great progress. Increased reporting of errors is definitely happening. Definitely improvements in the safety culture. We have new accreditation standards, national patient safety goals from the Joint Commission and others. International patient safety standards from Joint Commission International, new medication management standards, and we've done things like identify high alert drugs where it's more likely somebody would be injured, and hospitals really utilize that as a way to separate this group and take steps to prevent errors from them more than they would with other drugs. Next slide. And we have a list of high alert drugs on our website, of course, and we update this every so often. Next slide. Okay, at this point, I am going to turn it over to my colleague, Chris Mahalik, And she will follow through from here and go over some of the other good things that have happened as a result of our reporting that we wanted to update you on from the United States. Chris?
Thanks so much, Mike, and good day, everyone. A pleasure to be here with all of you. So Mike did a nice job sort of chronicling where we've come in the US with medication safety efforts and those that have been led by the Institute for Safe Medication Practices. And I'd like to talk to you a little bit about some of the technological changes that we've seen. We've gotten to the point where we've really been able to eliminate handwritten prescriptions. And one of the early adopters was the state of New York. And in 2015, they wrote a rule that said by 2016, it would be mandatory for all prescriptions for controlled substances to be sent electronically. And we're at the point now where more than 90% of US hospitals are electronically prescribing, and more than 90% of pharmacies are able to accept electronic prescriptions. And on the outpatient side, more than 80% of primary care physician practices have e-prescribing available. So as I mentioned, New York was an early adopter. Many states do require electronic prescribing for controlled drugs right now. However, there is some downsides, if you will, to it. When we've moved to complete electronic prescribing, we've seen different types of errors generate. So of course, through our error reporting programs, we learn about these and then we want to take some action on them. So one of the errors that we see is that screen selection errors have increased. And this is due to typing the first few letters or characters of a drug name. You know, very similar to when you're searching on the internet. As you start to type, the intelligence is trying to figure out what you're looking for, and it presents you with options. However, sometimes they're not always the options that you want, and it can select for you, or you can easily select the wrong medication. And we know from our other work that there are a lot of medications that share some similar letters. So we are trying to work on improving that selection, those selection criteria, to try and avoid misselection of medications that look similar. Next slide, please. So back in 2004, about 16 years ago, the US FDA required that certain human drug, biological, prescription, non-prescription medications contain a barcode. And this really helped us in the US to be able to implement barcoding during the medication use process. You know, in particular, in hospitals, bedside barcode scanning, where both the medication and the patient or the patient's identification band are scanned prior to administering a medication to them. We know from research that by implementing barcoding during medication administration, we are able to decrease medication errors by 65 to 86%. We are able to intercept those errors using that barcode check. We also use barcoding in community pharmacy when filling prescriptions, when we're looking at imaging during drug utilization review and adjudication, which is really just sending the information to the pharmacy benefit manager for payment. So barcoding has really been an advantage. It's very widely adopted in the US in hospitals. And it's also widely used in pharmaceutical care and the outpatient arena as well. Next slide, please. Another technology where we've seen increased utilization is what we call smart infusion pumps in the hospital setting. And this is just really beyond electronic rate control. These infusion pumps, they have the ability to provide limits, warnings, if you will, if somebody makes a key entry error. So in hospitals, we see about 90% of them employing a smart infusion pump. So an electronic infusion device with those limits built in. We also have some hospitals that are utilizing auto-programming, which is the message containing the information on the rate that needs to run from the medication order is electronically sent to the infusion pump. And the nurse at that point needs to review it and confirm it, but it eliminates a number of manual steps. And then as the infusion runs, the information about the rate, perhaps if we stop the infusion, if there's some type of warning, all of that information feeds back into the electronic health record. So you see we have a closed loop, safety loop, and we've eliminated manual steps that we know are error prone. And right now in the US, about 10% of hospitals are using that feature of smart infusion pumps. So 90% of hospitals are using the smart pump, and about 10% have that closed loop auto programming and auto documentation. Next slide, please. Another technology that's pretty widely used in hospitals is automated dispensing cabinets. These are used in the US. I know they're used outside of the US as well. There are definite advantages to automating storage of medications in patient care areas. You're decreasing the need to actually transport the medication from one storage area to another because it's already in the care area where the patients are, the wards. You're also decreasing the time for a nurse to be able to obtain a first dose of a medication. There's clear advantages on tracking and controlling controlled substances. And also, if you're looking for charge capture or a way to monitor inventory, they satisfy that as well. However, there are risks with them, just like any other adoption of a different workflow or different technology. It shows us sometimes some different risks that we may not have anticipated. And one that we see often is that the overuse of a feature called override. So these medications are linked to the patient's profile and the orders that have been entered for that patient, the medication orders. However, if there is need for something that has not been placed on the patient's profile yet, a nurse is able to use a feature called override. So it's essentially overriding some of the safety features of the machine, and we've seen errors related to use of that override feature. Next slide. Now, these are IV workflow systems, and we know from observational studies that have occurred years ago that there's a 9% error rate in compounding of sterile preparation. So, 1 in 10 medications that are prepared that are going to be used and injected into a patient can have an error. This is from observational studies. We also know from more recent studies that automation, adding in a workflow system like this where we're using barcoding and we may be weighing ingredients as well, we know from those that they are capturing a 7% error rate. And the majority of these errors were identified in weighing the ingredient, meaning that the majority of errors were the wrong amount of medication. A quarter of the errors were identified in the barcode check phase, which that means is that a quarter of the errors were related to a wrong medication. We also know from more recent studies that technology is able to detect 14 times more errors in sterile compounding than any manual checks. Now, all of these that I'm talking about are done in the pharmacy. In the US, pharmacy does a lot, the majority of sterile compounding. And in the US right now, about a third of hospitals are using some form of IV workflow systems. Next slide, please. So we do recognize that much of compounding, sterile compounding outside of the US occurs outside of the pharmacy by nurses often and on the wards. However, ISMP believes strongly that the best practice, and this is one of the targeted medication safety best practices that Mike mentioned earlier, we believe that the best practice is to use technology solutions to augment manual processes for preparing and verifying compounded sterile preparations. We see the data from the events, we see the data on what the technology is able to detect. We think that barcode scanning linked to a patient-specific medication order to facilitate correct identification of products used in the preparation of these compounds is the best practice. We also have compounding guidelines that call for the use of both barcoding and some type of gravimetric or weighing of ingredients to be really the standard for at least chemotherapy preparation and for pediatric sterile preparations. Wherever it's possible. Sometimes with very small volumes, it becomes challenging, but for the majority of the pediatric compounds, it should be able to be utilized. Next slide, please. Another strategy to avoid errors in compounding is to use pre-filled and pre-mixed ready-to-use products. And we see really too many nurses and anesthesia staff still preparing their own doses, which is really error prone. So you see here on the slide, we have a pre-filled syringe and we have a pre-filled infusion of an antibiotic. And we were saddened to hear, and I know the availability of pre-filled and pre-mixed medications is more limited outside of the US, and we were sad to hear that there was some available in France, and it actually was the company who manufactured it stopped the production because of lack of use, which is really sad. And that was actually for potassium chloride, which, as Mike mentioned, we were able in the US to eliminate those vials from patient care areas. And one of the things that facilitated that was the availability of pre-mixed bag of potassium chloride. Next slide. Mike and I have both mentioned different guidances and best practices during the talk today, and I just want to point you to a couple others that we have. On the left here is our list of confused drug names, and these are medications that practitioners reported to us through our reporting program of names that could easily be confused. In the middle is the FDA, US FDA and ISMP list of lookalike drug names with our recommended tall man lettering. And on the right is our list of error-prone abbreviations, symbols, and dose designations. And as we previously mentioned, all of this is available on the ISMP website, and it's throughout. I know we have it in the slides, www.ismp.org. Next slide. These are examples of practice guidelines related to things that we talked about today. On the left is our guidelines for the use of automated dispensing cabinets. These were recently updated, taking into consideration some of those error types that we've learned over the years of use of this technology. In the middle is our safe electronic communication of medication information guidelines. This really looks at how EHRs, how electronic prescribing systems communicate information. And on the right are our guidelines for optimizing safe subcutaneous insulin use in adults. Next slide. The International Organization for Standardization developed ISO 80369 as a standard. I think you all know about that. We started with MFIT in 2016. In the US, because the state of California made it mandatory, 80% of hospitals in California have converted to MFIT. However, the rest of the US lags a bit behind. I think our latest estimate was about a quarter of other hospitals around the US have converted to MFIT. And then, of course, NRFIT for neuroaxial connections was introduced in 2019. And this is also that the small bore connectors for a specific route don't fit into other small bore connectors for other routes. So the whole purpose, as you may be well aware, is that we avoid wrong route errors where an IV enteral errors, IV neuraxial errors, which have been very harmful and in some cases fatal, these misconnections. So we are still working on that. Next slide. And we can't forget the patient. Our patient is our last line of defense, and ISMP has worked on specific patient information sheets to address certain high alert medications, those medications that are more likely to cause harm when used in error. And you see on the slide here on the right is one of the examples of a handout for fentanyl transdermal patches. It's designed for a patient or a caregiver. And on the left are the other subjects that we have these leaflets for. And these are available on our consumer website, and the website address is different. It's on the bottom of this page. Thank you, Jordan, for pointing that out. It's consumermedsafety.org. So next slide, where do we go from here? Where do we still have room to grow our safety efforts? Well, we think there are a couple areas that we think are top on our list. First, we'd like to see a reduced reliance on nurses and anesthesiologists to prepare medication doses, to prepare these sterile medications outside of a pharmacy environment. To facilitate that, we'd like to see greater availability of pre-mixed IV medication solutions in those flexible containers like I showed you on the slide, and also greater availability and use of pre-filled, ready to administer medication syringes to support enhanced barcode verification, the availability of barcode or RFID on products, so that pharmacists can use them when doing sterile or non-sterile compounding, also on unit dose packaging and patient packs so that medications can be scanned at the point of care. We'd also like to see manufacturers adhere to guidelines that have been established by global regulators and the IMSN, such as the Global Initiative for Drug Product Labeling, Packaging, and Safety. And that's on the International Medication Safety Network website if you'd like to read more about that. Next slide. We'd also like to see the creation of an independent voluntary provider error reporting program, or partnering that really focuses less on big data and really more on what went wrong. And we feel that we've been able to do the most when we understand more details about events. And we'd also like to see increased cooperation between independent providers, error reporting programs, regulators, pharmacovigilance centers, and standard organizations. And cooperation between manufacturers and provider reporting programs. And finally, not forgetting the patient, that mandated patient education regarding information needed for the safe use of certain, at least high alert medications. So with that, we've come to the end of what we've prepared to discuss with all of you today. We do have some time for questions, and I'm going to call Philip back in, and we thank all of you for already putting some questions and having some discussion in the chat. We appreciate that as well. Philip.
Thank you, and thank you, Mike, as well. I think that was a very, very clear presentation. I don't see any questions being posted as of yet. With that in mind, maybe if I could ask one. We've heard a lot in patient safety in general about GS1 barcoding a few years back. And I saw you mentioning that and also mentioning RFID and so on. Could you clarify a bit more for the rest of us how that's impacting medicine safety and where we're at with that in the US compared to the UK?
Yeah, in the US, we use what we call the National Drug Code. Every drug, package size, dosage form from every company has a specific number on it. and it appears right down to the unit dose. As you know, there are some parts of the world that use the unit dose system, not the patient packs. The patient packs, I'd love to see more of here, especially for ambulatory care. But we do use unit dose, and that works very well with a barcode system. But it's a linear barcode. It is not a 2D barcode, which you have in Europe and in England. It is a linear barcode, and it only identifies the drug. It does not give you the expiration date. It does not give you the lot number. It does not give you any other additional information. My understanding is it is based on, and I don't understand it totally. I'm going to admit that right off. Maybe Chris, you do. But there is some relationship to the GS1. It's not the same number. I don't know what that is. It's supposedly compatible with it in some way, but we couldn't take one of your packages that we import during drug shortages and use that barcode that's on your package to scan the drug at the bedside, as we do here in the United States. So unfortunately, it doesn't work for us. I really think that we're getting closer and closer to radio frequency identification and making that tiny chip small enough that it could fit into almost any type of package. We are starting to see that here already. There are a couple of companies, Fresenius Kabi being one of them, that has begun to market their drugs with a RFID chip so that you would be able to go, for example, to a crash cart and know exactly what's been used, what needs to be replaced. I could see that in the future, it could get down to the bedside and special equipment there. Chris, I don't know if you have any comments on that.
Yeah, no, agree with everything you said. I wonder, just for completeness, if we should call David in just to comment. I know it's a little bit different, but there is a 2D barcode that's been implemented in the UK for the falsified medication directive. David, do you want to comment on that as well, just to get us complete?
Yeah, I've been trying to post some useful things in the chat box for everyone, but I've just posted something about, we have a thing called the Dictionary of Medicines and Devices and SNOMED codes that we use in the NHS in England. And that's how it all fits together. Unfortunately, the Falsified Medicines Directorate, it was a kind of wasted opportunity, because the medicine packs, albeit not the unit of use, but medicine packs have the 2D barcodes. But apart from some hospitals that use automated dispensing, the barcodes are not being used for medication safety purposes. And I raised this with government when I was working with NHS England, and indeed with private industry, that here's a wonderful opportunity. The actual additional costs have been taken up to meet the Falsified Medicines Directorate. We could make have real benefit in using these codes to prevent wrong medicines being dispensed and administered. And the view at that point was, well, that is considered a bell and a whistle, and we'll only do the absolute minimum to meet the European directive. So isn't that sad?
Yeah, it is sad.
So we've got, we've got barcodes on our medicines that we could use, but we have decided not to. And in fact, in a hospital, and often in community pharmacy, are often in supermarkets in England, and I'm sure across Europe, the pharmacy might be the only place in the whole store not using the barcode, which is just crazy.
Well, a lot of our barcodes are, a lot of our syringes and injectable meds have barcodes as well. And it really does help to prevent mix-ups. That's for sure. We get a lot of feedback like that. In fact, with insulin pens, we had a problem here that insulin pens would get reused on more than one patient. They simply change the needle and not realize that there might be blood in the solution inside the cartridge. And now we have a barcode on it that identifies the patient and the drug. So, you can make sure that only that patient is getting an insulin pen, the one that's theirs. And, lots of things like that come from being able to scan at the bedside.
And prior to the US FDA rule with barcodes, there were some organizations that were barcoding in the US, and what they had to do was really repackage or manually apply a barcode onto the product. And I'm talking about it in the hospital setting. And I know outside of the US, there are some organizations that have to go that route as well because of that importation of drugs from so many different countries that there's no consistency in even having a barcode that could be useful in the process to verify, correct drug, correct dose.
David, you mentioned, to bring up another subject, I saw while I was going through my slides, something came up on the screen about you using neuraxial connectors for anything that's injected via the neuraxial route. So intrathecal, epidural, whatever.
Well, spinal, I mean, again, we've kind of lost some momentum on this because we were very good early on in changing over to these non-Lure connectors. And then, of course, there was the ISO standards versions that needed to be developed and come in. But of course, because there's a view now that top down is bad and hospitals have to decide for themselves whether they should be using these connectors that have taken years, well, one might even say decades to develop. The coverage in the UK, particularly of epidural non-Lure connectors, is very poor, and only a fraction of the hospitals is actually using these devices with the bespoke connectors now. So again, work has been done, but it's not been followed through with national oversight, sadly.
Well, we do have the NFIT going. 25–30% of hospitals have implemented that. That's the special connector for enteral, to prevent drugs that are intended for enteral use to be given intravenously or even intraspinally. We've had that happen too, because of the Lure connector commonality. But the neuraxial connector, we are just now starting to see a couple of hospitals that are using it, and only for regional anesthesia. We're not seeing it for drug injections. And most pharmacists don't even know that it exists. But there is the NRFIT that Chris mentioned. And I expect that, we'll see some progress coming up with that. I hope anyway.
I would think the oral connector is far more universal in its implementation, certainly in England and UK. I think we've gone over to that pretty much. I can't be thinking that we're using a lot of Lure connectors there at all now. I would think our take-up must be in excess of 90%.
Okay. By the way, everyone, I really should mention my colleague David Cousins was recently is going to be recognized by ISMP as our lifetime achievement winner. He has done so much globally, not just in England, not just in the UK, but around the world through his work with IMSN and others as well to reduce medication errors, that we couldn't find a better choice to recognize with our annual Cheers Award. Our Cheers function, by the way, is an annual event that's held in conjunction with the American Society of Health System Pharmacists meeting, which this year, of course, because of COVID, is going to be virtual. But we expect a really big turnout for that. And we are honored to be able to honor David Cousins with that. So thank you, David.
Well, very kind, Mike, but can I just say that to some extent the tide has come in and the tide has gone out a little bit on some of the medication safety activities in the UK. And if you've looked at the chat box, you will see that publications like your own from ISMP are something like I'm describing as unique. We had something similar in the UK maybe 10 years ago, but we don't have anything similar anymore. We can't read details of medication error events. They'll give you numbers, but no longer will they be prepared to give you any details. When by details, I do not mean name of patient, name of staff, name of hospital, just the details of what happened. There seems to be almost an idea, an interpretation of data protection laws that you can't even describe what happened. somehow that's invading the data protection for an individual, that you can't describe 1 case, 5 cases, 20 cases where some learning had to come out. But unless you can describe the case, how can you take the learning?
Well, I can tell you that ISMP and ECRI, if there's anything that we could do to help with that situation, you know, obviously we'd be glad to do that, you know, but we do think that's something that needs to be discussed. You've got to get the information out there, and that's what's really helped us make progress. And
can I just make one last observation? And this is coming out of the COVID experience. And again, it's something that I've put in the chat box. But in the autumn this year, NHS, or indeed Department of Health, has put out a document, and I would, you know, like everybody to see it, even in other countries, called Transforming NHS Pharmacy Aseptic Services in England. And it was being prepared before COVID, but COVID has made the observations even more clear, that they're actually saying that they're going to put a huge investment into aseptic services in pharmacy, and that they're actually saying that it releases huge numbers of nursing staff at a time when we desperately need nursing staff, and that nursing staff should no longer be preparing injectable medicines in clinical areas. And during the COVID outbreak, when hospital pharmacists went to the wards and helped prepare injectable medicines, it became absolutely clear to them that this would be a major improvement, both in terms of efficiency and safety. And so this is probably one of the most significant reports that have come out from the UK in a long time. A big investment in aseptic services in the preparation of injectable medicines in the pharmacy, and indeed outside of the pharmacy in sort of semi-industrial automated facilities with standardized doses, etc., being used throughout the NHS.
Well, I agree with you, David. As a matter of fact, both ECRI and ISMP, during COVID, we created special sections of our website. There is a lot of information that's freely available. Our entire newsletters were freely available. And, you know, ECRI has a section on their website as well. I hope people will take a look at that. And we say many of the things that you just said. So,
well, it's good when government says it. I mean, they're talking about freeing up 4,000 nursing staff for patient care, and that it was going to, you know, release over 1 million hospital bed days at a cost of £346 million if we can only get the preparation of injectable medicines in the pharmacy. So I think, you know, this could be very interesting to other European countries that are not currently preparing injectable medicines in the pharmacy. Maybe something good can come out of the COVID experience.
Yeah, great share, David. Great share.
Yeah, certainly hope so. Well, David, thank you very much for being with us and being on the panel. I'm learning a lot every time I talk to you. And Philip, I'll take it back to you. We're going over a little, and we want to be respectful of people's time. So thank you.
Thank you, Mike. Thank you, David. Thanks to our panelists. We've had a few questions about people asking where they can view this presentation again. So I'd like to encourage everyone to look at the ISMP website. There's, I believe, content on YouTube as well, if I'm correct. And
yes.
To keep an eye on things, and we'll post this presentation very soon. So yeah, the ECRI website and the ISMP websites are worth looking at. With no further questions, I'd like to thank Christina, Mike, and David, especially for joining us in UK and helping us with this webinar.
Thank you.
Thank you.
Thanks very much. Goodbye.